Hi, everyone. Hi. You're all very welcome to be here with us today. My name is Elisa. I am from the Department of Obstetrics and Gynaecology of the RCSI. Just giving you a brief welcome and then hand it over to Claire for our panel discussion. This event is part of Bias Inequalities in Women's Health and Research. It's a Science Week funded event, funded by Research Ireland. Today is all about exploring the past, the present, and the future of women's health, and hearing from incredible experts who are shaping that future. We're going to record the event. With us today, we also have our lovely Robin Deasy, who will live sketch the event. Looking forward to see the end result. That's all. Thank you for being part of Science Week, and I'll hand it over to Claire for now.
So we have ISL interpretation today. You can see Orla hard at work there, and we have Quiva as well. So thank you so much for being here. I'm going to introduce our panel now in no particular order, because we very conveniently sat in the order under our slide pictures. But we have Professor Fergal Malone, who's under his picture there. Fergal is Professor and Chair in the Department of Obstetrics and Gynaecology at the RCSI School of Medicine, and Fergal is a Consultant Obstetrician at the Rotunda. Next to Fergal is Professor Jennifer Donnelly. Jennifer is Consultant in Obstetrics and Gynaecology and Maternal-Fetal Medicine Specialist at the Rotunda. And then we have, jumping over to Harriet. Harriet Wheelock is Curator of the Heritage Collection at the Royal College of Physicians of Ireland, not in Ireland, of Ireland. And Dr. Cliona Murphy. Cliona is National Clinical Director of the National Women and Infants Health Programme. So with all those formalities done, and Robin has very kindly written all the titles on the slide in case you forget any. Robin, I hope you're getting my best side here. I'd like to ask each of you about the work that you do. Harriet, can I start with you? What's involved in your job?
Hey, thank you very much. And it's very nice to be here. So I am an archivist by training, and I look after all of the collections, the heritage collections in the College of Physicians. So it's a library, archive and object collection. We're an accredited museum by the Heritage Council, which is to do with how we look after the collections. And my role is to preserve the collections and to make them accessible to researchers and to the public.
Brilliant, thank you. And Cliona, how about you? You're National Clinical Director at the National Women and Infants Health Programme.
So a bit of a handful and mouthful. So I'm a consultant obstetrician gynecologist. So 1 day a week I would work as a gynecologist and see people and operate. And the rest of the time I work with the HSC. So part of that role is getting involved in various projects as part of the National Maternity Strategy. So some of you may have heard about, postnatal hubs being rolled out in various regions across the country. So trying to engage with the regions, how they're recruiting, how the infrastructure is working. We also have national guidelines come from the National Women's and Infants Programme. We also have a big kind of gynecology program where we're involved in both guidelines and rolling out new initiatives, for example, around ambulatory gynae clinics, which have been rolled out across the country, speeding up access to gynecology. So these type of initiatives that need a kind of a national focus, not just a regional focus.
Great.
So it's quite interesting.
Yeah. And what a good mix as well for you as a clinician who's also involved in developing these guidelines and which feed into policies and ultimately improve practice over time.
So we do engage with both the hospitals and the clinicians on the ground and the management on the ground, but then we also engage with the Department of Health and Policy Unit in the Department of Health. So I suppose, spanning those areas.
Very good, very good. Thank you. Jennifer, tell us about your work.
Thanks. So I'm a consultant obstetrician and maternal-fetal medicine specialist, and I work in the Rotunda, and also I have some sessions in the Mater Hospital. So the vast majority of my job is working with women, pregnant women and people who may have an issue with their pregnancy, for example, have an underlying medical condition or an underlying problem with fetal development or screening for that and managing of complications that arise during pregnancy. So as part of my job, I often kind of will see women maybe who are on medications during pregnancy. And so I think, and that's where a lot of my research interests have been focused upon, because as we're going to be chatting about over the course of the day, that the access to those medications isn't always straightforward.
Yeah.
So
Yeah.
that's what I do.
And
that's
people's
really
understanding of those of how which ones are safe as well is
exactly
be a
and
little
kind of
bit
talking to people about medication safety in pregnancy and
yes.
about how to manage things during pregnancy, which can be a time of kind of obviously of happiness and well-being, but also kind of certainly of anxiety, particularly if there is other issues going on, be they medical issues or fetal issues.
Okay, thank you. And Fergal, tell us about the work you do.
Well, I think I'm one of those lucky ones who has what I think is an ideal job, in that I have a lovely blend of clinical and academic work. A couple of days a week, I look after pregnant patients, deliver babies, and actually shared with Jen, we run the fetal therapy program in the Rotunda, where we look after literally the fetus as a patient. So be it treatments directly to the fetus that's in trouble, needs to be it surgical or medical treatments, which is really cutting edge and exciting. But then in my other hat is the academic side, which is involved with trying to, teaching the medical students, but also trying to foster the next generation of obstetrician gynecologists, identifying who they may be, stimulating our best and brightest medical students to hopefully do a career in obstetrics and gynecology, and then using that training program to hopefully help deliver our research programs as well, and try and push forward a research agenda in obstetrics and gynecology. And those hats seem to fit very nicely together. And for that reason, I think it's a lucky job to have.
Sounds good. Sounds good. All right. So that's what you're all doing today. I want us to look a little bit back into the past now. This is the then of Women's Health and of Science Week. I suppose, why and how have women been excluded and underrepresented both in research and practice in obstetrics and gynecology? And Harriet, maybe I could ask you, but could I ask you to pass up the mic? Thank you. I suppose in terms of obstetrics as a practice, looking after women who are pregnant and having babies, in the past, that was very much a woman-led profession, wasn't it? Why did that change?
Yeah, so in the kind of 16th and 17th century, it was largely a female-led profession. So there would be, a wise woman or a midwife in most areas, and that would be where women would be getting their care. So when my college was founded, our 1692 charter, which is our founding document, it regulates the physician practice in Ireland, but it also regulates the midwifery practice. And they're seen as two separate things. And in fact, for a long time, you can't hold a license in both. And the very first application we got for a license to practice as midwife was from a woman. So it's from Mrs. Cormack. We don't know anything else about her. Mrs. Cormack, she is our first female licentiate. And in fact, the first sort of about the half dozen licenses that were issued, they're 50% go to men and 50% go to women. So it's clearly a practice that is both. But really into the 18th century, as midwifery becomes more, I guess, is looked at more through a scientific gaze, it's seen as a bit more kind of respectable for male practitioners to get involved, and it becomes medicalized. The women are sidelined because they have no access to the medical training.
Okay.
And there are female midwives who are writing books saying, look, we've been doing this for centuries, we know what we're doing, we have all this experience, and you won't use it. So Jane Sharp, who's a midwife in the UK, she publishes a book, which we have in our library, where she talks about this. So there's this real tension between the women who've been doing it for a long time and the men who are coming in and saying, this is a science, it needs to be, medicalized, it needs to be taught, it needs to be structured. And so the women are then excluded.
Yes.
And it becomes a part of the medical profession, and then eventually into the medical career. And you can be both a man midwife, as they were called.
A man midwife. Okay, I love it.
A contradiction into it.
I suppose the women were saying, don't go reinventing the wheel. We know the wheel.
Yeah, exactly.
Yeah.
Like, we understand this. When we understand our bodies, we understand other women's bodies. We've been through this experience. And so it changes the way it's looked at completely.
Okay. That's so interesting and there was that barrier to women, I suppose, practicing then.
Yeah.
And then, of course, I guess the world of research is often informed by the people who are practicing. So
exactly. Yeah. So the research is then
different
coming from
lens.
males.
Sorry, Fergal. I apologize for giving out.
But I think for a lot of women, into the 18th and 19th century, they weren't going to male medical. They couldn't afford to go to a male medical practitioner when they were pregnant. So they were still relying on this network of knowledge among women, but it's become they're being pushed out of the mainstream. So,
Okay. Okay. And has there been there's been a redress since then? So when did women start becoming able to practice medicine and practice as
So the campaign
obstetricians?
for women to enter the medical profession really it's the mid-19th century. And there are several continental European universities which allow women to study medicine. Zurich, a lot of the early female doctors go there. But in the British Isles, the Medical Act doesn't say you can't be a woman practice medicine, but none of the qualifying bodies will allow women to take their exams. And so Sophia Jex-Blake and a number of other women, the Edinburgh Seven, they study medicine in Edinburgh, but then
The Edinburgh Seven.
there's 7 women who study medicine at Edinburgh University, but they're not allowed to be given their degrees, so they become known as the Edinburgh Seven.
Okay.
And they really push the government to allow women to study medicine. So the Enabling Act is passed, I think 1871, which says that the qualifying bodies, if medical qualifying bodies, can choose to allow women to sit their exam. No, can choose to allow people with a degree from a foreign university to sit their exam. So which then allows women in. So they don't specifically say it's about the female aspect of it, but it is.
They kind of opened the back door somewhere.
And all of these women write in, and the College of Physicians in Ireland is the first place to allow a woman to sit their medical exam. So the first, I think, about 25 women to qualify in the British Isles qualify through physicians. And obviously once one organisations let them in, everyone else like, well, we're going to have to do it as well because women can get in. But obstetrics is seen as a particularly suitable specialty for these women. And pediatrics, but obstetrics particularly is seen as something it's sort of more suitable for them to go into.
Yeah, interesting. And that's from a practice perspective. What about from a research perspective in terms of obstetrics? Maybe I can ask our consultant obstetricians this question. In terms of research in the past, how much evidence has been generated about how obstetrics is practiced?
So if I may, Dublin was quite famous for reporting certainly on outcomes in obstetrics. So the hospital reports were very interesting, and they were very diligent in reporting outcomes and what happened to individual women. It was nothing like GDPR then, so there was all very fine detail, and they're really interesting to look at from the 1900s, from the 1800s, 1900s. But if you look, it's all focused on obstetrics. So I would say for a long period of time, research or reporting in any form was really through the prism of obstetrics. So women, patients were between the ages of 15 and 45, but it was as the, reproduction was key, whether they were having babies or trying not to have babies, it all
centered around having the babies.
I think it's fairly recently, a lot of the focus really was on obstetrics, and I think that's beginning to change now because not all women want to have children, and people are living longer, but that was initially the focus. But Ireland was, Dublin was quite famous for its reporting, I think, and maybe Fergal will talk a little bit more about the research side of it.
Yeah, I mean, as Tina said, before anyone knew what audit was and publishing audits, the 3 Dublin maternity hospitals were publishing audits of what happened, and it's one of the best examples of really early research and the openness in which you could see exactly what was happening in the hospitals, and as Tina said, detailed clinical vignettes that you wonder how they got away with them now, because you can actually make out from some of the stories, oh, that would have been the lady down the street who, oh, I know that person, so obviously you can't do that now. But a lot of the limits on research in obstetrics that were historically put in place was because of an overly paternalistic approach to protect women and their pregnant and their unborn child from drugs and medications. And so research studies, research protocols that were published almost invariably had an exclusion for, well, obviously you can't include pregnant women in the study, initially with probably a good intent to protect the fetus from potential harms. And we all know about thalidomide effects and things like that. So out of fear for not replicating the thalidomide effects. But of course, it swung the pendulum so far the other way that it meant that there was so little research done on pregnant patients, on fetuses, because in this desire to protect them from harms, it actually probably has caused harms, because the vast majority of new drugs that are launched, there's actually limited data available on their safety or efficacy in pregnancy, because upfront, pregnant people were just excluded from the studies. So I think about 90% of new drugs in the last 20, 30 years approved by the FDA have no data on safety in pregnancy, which of course means that pregnant people do not have access to those drugs. So if we look at when we manage patients with hypertension, the drugs that we use for managing hypertension, internal medicine docs, cardiologists laugh at them. They've been using that drug 30 years ago. Can't believe you guys are still using that drug. Well, we are, because it's the only ones that we have data on safety. So this historic approach of protecting women and their unborn child from the dangers of research has actually negatively impacted on the healthcare of women and their babies.
Absolutely.
Because of limited data.
And is it fair to say, sorry, Jen, before I come to you on that, is it fair to say that that has had an even wider effect, that people can be excluded from things like clinical trials or studies on the basis that they may become pregnant?
Oh, absolutely. If you're of childbearing age, I've seen research protocols where that's in the exclusion of childbearing age for fear that, and whether it's litigation or other reasons like that, just this absolute fear of, oh my God, what if we recruited that patient to study drug X and then she suddenly is found to be pregnant? So let's take the safer option and let's just exclude her up front.
But that in turn means that people of an age where they could become pregnant means they're not included in a lot of studies. So the data, the safety and efficacy data we have are for people who aren't those people.
And that's right. But there was some biological plausibility as well to some of these arguments. Some medications and how they are metabolized might be impacted by things like estrogen levels and changing hormone levels. So people knew about changing hormone levels, said, oh, hold on a second, now that's going to make the interpretation of the data too hard if I don't have data on when in someone's menstrual cycle the blood sample was drawn, because maybe there's an estrogen effect at that time of the cycle, but not at that time of the cycle. So do you know what? Let's just exclude.
We'll just remove the co-founder. Exactly.
Yeah, exactly. So
And
that's
confounder,
historically the challenge here.
Exactly. Jen, did you want to say something there?
Yeah, I mean, I suppose just to kind of back up some of this, or to re-emphasize some of those things that Fergal has said in relation to medication safety, particularly in pregnancy, that women are also, because of a fear, are stopping taking medications that can have very serious implications for their health. Mm-hmm. So, for example, somebody who has got epilepsy, who is on medication to prevent seizures, and we've seen obviously there's a huge focus on that at the moment in our with valproate, but that's because pregnant women have been excluded from use of that. And so maybe, and it has been only from case reports where people have seen that there are issues. But if we think of who is pregnant, who is of childbearing age, over 1 million women in Ireland currently, could potentially become pregnant at any time. And over 90% of pregnant women take medication at one point in time throughout their pregnancy. So it's really imperative for safety that we find out. And if you just look to some other new drugs that have been life-changing, say, for example, for women with cystic fibrosis, the receptor modulator medications, that again, pregnant women were excluded from that. But in fact, women who weren't yet pregnant were on the medication. So many more of them became pregnant because with the medication, their health was better, and then they became pregnant. So we got information about safety in pregnancy through someone who had to be excluded from the trial because they became pregnant, and then the data came from there. That's not the way to design them.
Yeah, absolutely. So that was then. Let's move on to now. I suppose it's not perfect yet. There are still gaps in our knowledge. I think the Health Research Board recently actually did an evidence and gap map about what research evidence is there around interventions to support women's health. And they did find some very big gaps in OECD countries. One of those actually is in endometriosis, which is, maybe, Cliona, you can explain to us a little bit about what endometriosis is. As far as I understand, there's a lot of research in the pipeline about how to treat endometriosis, but we're not there yet and there's kind of a shortfall between that research and practice. So what's been happening in that space in Ireland?
So endometriosis is a condition that affects women. It's primarily gynecological condition. The prevalence, even we don't really know the true prevalence, so that's for starters, but they estimate, it used to be the estimate of about 1 in 10 women. Now they're saying maybe 1 in 7. And in some ways, probably the prevalence has increased as life has become more industrialized. And it can affect people in various ways. So the effects can be from abdominal pain, kind of every month, to, you know, really severe pains, to in some cases, symptoms that you wouldn't associate with periods, you know, with bowel symptoms or bleeding from the back passage, etc., or symptoms like having shoulder pain. So it can be really what we call protean. It can affect different systems, but it can affect, you know, anybody from adolescent to kind of perimenopause. And so there's a big lack of knowledge around the prevalence, about how it affects people, and then the best type of treatment. So a lot of the, I suppose, focus has been on surgical treatment for it, but we do know that there's lots of gaps there. And there are medical treatments also, and most women who have it will need a combination of medical and surgical treatments throughout their lifetime as such. And it's really the type of thing that needs to be individualized. You're really talking about individualized medicine there. And, you know, the patient experience is really important. And so we don't have a lot of that patient experience research. There are now some new drugs coming forward, which is going to be a real advance. So making sure that they do, you know, firstly, come to market, you know, that the proper trials have been done, but then come to market, and then that there's access, you know, for people. So there's a whole process when it comes to drugs about, you know, getting them to the market and then getting them, you know, at a reasonable price to the public. So
yeah, absolutely.
all of that is really important. But it's just one example of a disease that in the past was, I suppose, lumped in with other gynecological disorders, but very little attention was put on it. But there has been a lot of attention in the last while.
And we now have a national framework, don't we?
have a
Yeah.
national framework now, recently launched from the National Women and Infants Health Programme. That, you know, essentially is a sort of framework where things will hang on it. So, you know, it goes from primary care to secondary care to tertiary care, and sort of, you know, as a roadmap for how we'd like services to be. We're certainly not there yet, but also needs to be linked in with things like information campaign and other ancillary services. So again, you know, not focusing on just surgery, a sort of a wider awareness with regard to, I suppose, the community and the GP community. Those in the emergency room, there's evidence that people with endometriosis have visited emergency rooms, you know, 5 or 6 times before they get a diagnosis. And this is not just in Ireland, it's in the UK and in other countries. It's similar research, qualitative research has found this. So getting that awareness to people who don't deal with the disease on a day-to-day basis, but may come across patients, and having it on the radar. So emergency room, you know, people, doctors working in radiology, doctors working in other areas, in surgery, etc. I do remember years ago when I worked in surgery in Cork, we had a patient who had an operation for bowel disorder that seemed to be coming fairly regularly, and we thought it was Crohn's disease.
Right.
And it turned out it was endometriosis. But that was, you know, at that time a case report, and maybe we moved on and nobody really thought any more about it.
Yeah.
And there was no sort of linking in with the other specialties and doing more around it. So
Okay.
I think we are going to see improvements in the next few years, but that includes, you know, looking at things like other drugs. You know, are there other things that can be offered, because not everything will work for one person, and also being cognizant of the patient as, you know, a person of 18 is going to have different needs to a person of 45,
Sure.
48, etc. But there are a few other illnesses like that. Something like multiple sclerosis affects women 10 times more commonly than men, and many people will know very little about it. It's not in any newspapers. I see quite a few women with it, but it's just really interesting that there's very little about it.
Okay.
Very little research.
What's the name of the condition?
Lichen sclerosis.
Lichen
It's a
sclerosis.
skin condition.
Yeah.
But because it affects women 10 times more commonly than men,
Right.
you know, it's almost invisible.
Okay.
So there are other examples of under-researched
Yeah.
conditions. So more to be done.
More to be done. Absolutely. Harriet, I'm curious that you make the collections available to researchers who are interested in exploring these kind of gaps in our knowledge. What kind of gaps are people exploring now with that information from the past?
We do get, we get obviously historians, and we do also get clinicians in coming to look at the material. The reports that you mentioned, they're printed annually in the journals and have been for centuries, I guess, at this stage, and they are used a lot. Actually, we have a lot of people come in to look at those, and they're looking at that kind of long history and tracing trends. Actually, I should talk about skin diseases. Some of the illustrations we have of skin diseases are used partly because if you're practicing in the West, they don't get that bad anymore because we can treat them so much earlier that we have drawings, and very graphic drawings, of some skin conditions that you just don't progress to that stage anymore with Western medicine, although in some other countries they do. So they get used, which I find really interesting. There's these representations that are not presenting, but then some doctors are starting to see things coming back in, particularly around stuff with vaccination, where cases, you know, diseases that had been nearly cleared out by vaccinations are now starting to represent again. And younger clinicians may never have actually seen cases because they just didn't occur. So there's some things that are definitely improving, then others that you see it sort of almost regressing slightly.
Right. Okay. Wow. Have our audience any questions for our panelists? If you do, put your hand up and I will come to you. But I did want to ask Jennifer and Fergal about the kinds of work, the kinds of work that you're doing today that can help people into the future, I suppose. I mean, Jennifer, you do a lot of work on medication in pregnancy, things like aspirin, heparin. Tell us about those studies that you're running at the moment.
So I suppose we've just, we've spoken about lack of access to treatments in pregnancy, and one of the major both killers and causes of severe morbidity in pregnancy is venous thromboembolism, or a clot in the leg or lung.
A clot in the leg or
in
the
the
lung.
leg or the lung. Yeah. And a lot of because we know that it can be so prevalent associated with pregnancy, no trials have been done to show what dose is the correct preventative dose for how long. And so with the support of RCSI, we were part of an international study, which was the first study done to actually provide evidence for what kind of medication, what dose of medication is the correct one to prevent blood clotting in pregnancy. And that was a study that was published in 2019 called the HILO study, and 2021, but we started the process in 2014. It was a multi-center study, but it was also really hard to get ethics because we were using medications that are unlicensed in pregnancy. So although we prescribe all the time, and there's millions and millions of doses of low molecular weight heparin prescribed yearly around the globe, it's actually not licensed for use in pregnancy. And so to get the ethical approval for that was quite difficult, but it just shows that it is being used on a daily basis in all of the guidelines. So it's really important that we look at that. And we're just starting, hopefully soon, a new study with RCSI looking at postnatal prevention of blood clots and looking at, rather than injections, aspirin, the use of aspirin. And then, of course, that's in a post, because we know that labor and birth can be associated with a lot of complications that are unpredictable, that increase the risk of blood clotting. And therefore, it's important to make a risk assessment of the likelihood of that in the postpartum period, and that period is a period of great change. And also for people who've just had a baby, it's a time where they're getting used to so many things, and looking out for taking medications can be more complicated. So doing research in the postpartum period can also be difficult. And also people are concerned about breastfeeding and the impact of medications on breastfeeding.
And there's so much going on in their lives. Their compliance might be an issue as well.
Because they're too tired,
they might not have time to take the medication.
Although I think one of the things that I've certainly learned over the years, and I think that's something that Fergal touched on, is that, in the past, things have been very paternalistic, but it's very important that, you know, we work in partnership with women, people, patients, because they have their own best interests at heart, and they're really motivated to participate, of course, because they want the best care for themselves and for their babies. So
Absolutely.
they're really motivated to take part, and we really saw that.
And on the basis of your research, Jen, are you seeing practices changing now in how we prevent and manage those clots in the leg and lung that can be so dangerous?
Yeah, I mean, certainly now we've got good evidence to give people the right dose so that they don't need to be on a higher dose, which a lot of people were on a higher dose, which is leading to increased bleeding complications, for example, and so that has been really important. And again, it was done, you know, and we'd often seen women who'd already experienced a clot and then were very nervous about participating, and they know that their risk is increased and they want to do the right thing. They want to take the right medication. And also it's really heartening to see how they're so interested in helping others to get that information. So even if they're thinking, well, I'm not going to have any more kids, but I hope that this information can help other people who in the future, and it certainly has.
Very good. That's great. And Fergal, what kind of research have you been involved in recently?
Yeah, so speaking of challenging research, I mean, one of the areas that we're particularly interested in is research around labor and birth. And as you can imagine, very difficult to do research in labor and birth, because when do you approach a patient for consent? When do you approach a patient for informed decision making if they're literally in the throes of labor? Yet at the same time, it's a group of patients, it's an area in healthcare that we really need data on. So over the last couple of years, we've been doing a lot of work on predictors of when labor might go wrong. How would you predict in advance if someone's going to have a simple natural birth or a complicated birth? And Naomi Burke, who's now a consultant with us in the Rotunda, and Neve Murphy, who's a consultant with Cliona over in the Coombe, they did their MDs with us over in the Rotunda on predictors. What things can you look at? Measurements can you do that might say, right, this patient is more likely to have a simple birth, this patient more likely to have a challenging birth. And then that's led on to other research into the area of induction of labor. Sarah Nicholson completed her PhD with us recently, where we had more and more patients seeking induction of labor, but very limited resources with beds. So how do we handle those increasing pressure demands? Well, what if you could, if someone wanted induction of labor, what if you could start the induction of labor at home and keep the patient at home for as long as possible? A, is it safe? B, is it effective? And she did a huge study on that she published in the Lancet that showed very good results. And then, because it was a controversial area, researching induction and birth choices tend to be very polarized, very political views on birth choices. So we got a lot of heat for doing research like that. So we decided, you know what, the next logical choice study would be, let's survey and research women's opinions on what do patients want in terms of as their pregnancy progresses. So a lot of people think they know what patients want. Why don't we listen to patients and ask patients what they want? So Rebecca Bocton, who's doing her MD with us at the moment, is doing the Born study, where she's looking at large numbers of patients before and after they deliver to see how did they get on at 38, 39, 40, 41 weeks. How many patients actually do go into spontaneous labor and have that simple, perfect delivery? Great. But how many don't? And then linking those outcomes to their opinions, and getting their opinions on their birth choices before they enter labor, and then following those patients up already. And she's already got over 600 patients recruited with multiple time points, their opinions. So we hope to be in a position soon to actually give real world data on what do women want about their birth choices. So it's a challenging area to research, but very important.
Absolutely.
And very important to be able to speak with data on these things, as opposed to what camp you
hunch
come from,
or
you come from, or political view you have.
Exactly.
But it has to be data driven. So
And
that's very exciting.
Is the Born in the Rotunda study still? Are you still recruiting?
Yeah, we're about 600 patients in, and she's hoping to get to 1,000.
Wow.
And she's flying it. She's doing a great job, and we have a great team like Elisa and Holly and Zara. We have. One of the great things we have with RCSI is in OBS and Gynae is they funded a research infrastructure. So we have statisticians, research assistants, managers, data managers, assistants with grant writing, all those challenging things that make research hard to do. We have that there so that young, hungry registrars coming up through the ranks saying, I'd love to do an MD or a PhD, but it's too intimidating to get the ball rolling. Well, hold on a second. We have a research infrastructure. You can come work with us. We'll give you a project. We have a whole team behind you. You can run with it. And we've got some great outputs from
That's brilliant. That's great. We have lots of questions in the audience. What's your question? Harriet, I can give you. I can.
Oh, okay. I might comment on that. So I work with the Women's and Infants Health Programme, but there's a lead midwife, Angela Dunn, works alongside me. So we've a very collaborative team, and I would have some clinicians working with me. She also has midwives working with her. So I would say we're quite lucky in this country that actually it's what we refer to now as the multidisciplinary team, so within hospitals you have your midwifery team working alongside obstetricians, and that is the best care for people, for women and babies. So some may need more medical input, for example, from Fergal and Jen. Others may have a more straightforward pregnancy, and it's much more appropriate for them to have, midwifery-led care. And that is working out quite well. In other countries, you have seen a little bit more of a schism, I think. But it is really important that we all work together. And I think, what I've seen from traveling across the 19 units in this country, that actually it's the multidisciplinary team, and not to forget also the allied health professionals, like our physiotherapists, like our social workers, like our dietitians, that also contribute really well. I don't think it's necessarily quite like that. There are choices with regard to which stream. There are different streams of care that people can access, and a lot of that can depend on the type of pregnancy, sometimes the type of birth that they're hoping for. So some will choose more midwifery-led care, maybe like a pool birth, for example. But in many cases, people may need a combination of both.
And more, I suppose, for example, a lot of the clinical work that I do, both for fetal issues or maternal issues, people don't want their pregnancies to be defined by the problems. And I think at the moment, a lot of our structures are like, I've come today from my cardiac clinic. So women who have an underlying cardiac condition that are pregnant, but actually like the main part of their life is that they're pregnant right now. Their cardiac condition has been with them for in the past. It could be congenital, it'll be there into the future. But because of the way that our structures are set up, often those women can be excluded from midwifery-led care because of this additional risk. But I think we need to be looking into the future. But whereas in fact, they need the holistic care of midwifery support throughout the pregnancy. And I think that's something that we're hopefully are moving towards, so that people can not be having their pregnancy defined by what's wrong, but actually that we can manage that safely and work together as a multidisciplinary team with midwives providing the holistic support, with obstetricians providing the medical support, and then if pharmacy, dietitians, all of those coming together. And that's what I would see the future, that people often are very scared with underlying medical conditions, or if there's a fetal issue. And that's one of the heartening things doing both fetal and maternal, that I can see fetuses being diagnosed with very serious cardiac conditions. But then I also have a woman with a similar condition who's had it operated on as an infant and is now having her own children. And that's really lovely to see, and is very heartening sometimes for parents to hear that that is in their future.
I would completely agree with that. It's interdisciplinary learning has been really at the forefront of what we've been done here for many years now. The idea of trying to break down silos and having people working together. I worked for many years in the US. I know a lot of colleagues in the UK, and unfortunately, I think midwifery and obstetric care has become very siloed in those countries, whereas in Ireland, well, it's not perfect here, but the mutual respect that I see every day of the week in our maternity hospitals between midwives and obstetricians is incredible, that I haven't seen in other countries. And that fosters mutual trust and working together and doing research together. So, for example, some of the studies that I mentioned there, the home induction study and the born study, we have midwives involved front and center in the design of the studies and the carrying out of the studies. And if you take the highest of risk patients that Jen and I see with the most complex fetal surgical procedures, we have midwives on the team who step in, and just because those patients have an incredibly complex case doesn't mean that they should be deprived of the added value that the midwife brings to her care. So we value, even if it's the highest of high risk with a medical model of care, midwives absolutely, and other specialists, allied health professionals that Cliona mentioned, are key to what we do. So we have for quite some time now moved away from silos, and it very much is interprofessional learning, multidisciplinary, and we do that not just in care but also in research as well. Well, first of all, I'm sorry to hear of your difficulties. I think we all, certainly the obstetrician gynecologists here, would all acknowledge that from decades, gynecology and women's health has been relatively underfunded and under-resourced. I spent 7 years as CEO of the Rotunda, and one of our biggest goals was to try and drive additional new funding for women's health care, women's health research, and physical infrastructure. And one of the big things we've got is people like Cliona, clinicians in national leadership positions, in a position to talk to the policymakers in Department of Health and the funders in the HSE. And while it's absolutely not perfect, but it is much better than it was. We are now, when I started off as CEO of the Rotunda, we had about 200 new referrals a month for gynecology. Recently, we're now up to 800 a month. And, their waiting lists have gone way down. And a lot of that is we have finally been effective in convincing the policymakers and the funders that women's health needs more funding. And it's been reasonably successful, although more to do.
So again, to acknowledge, what you've gone through, but I think it does highlight that there are some conditions that, span, it's not just gynecology, that, it spans other disciplines. And I suppose we could do more to integrate, how do hormones affect other conditions that people have? So, for example, somebody might have a rheumatoid condition. It may flare up, but sometimes other than others, compared to others. And also a little bit more, I suppose, education in some of the other specialties with regard to the effect on, for example, migraines, other areas of the body. So there is a bit that we could link in a bit more. And as I said, we have reached out to the emergency medicine physicians, and we're trying to do a little bit more linking in there with regard to, I suppose, knowledge, awareness, and having integrated guidelines. So there definitely is more to do. And you do mention PMDD, which is, an uncommon disorder, but probably unrecognized more often. And there are some reasonable treatments for that. But again, I do know that people struggle in accessing the person who knows a bit about it and can give the treatment. So, there are difficulties definitely that could be improved. And, we're striving all the time to try and do that. Sorry, Jen.
Oh yeah, no, just to say that thank you for sharing that. And, I think it's people speaking up about their own experience that highlights it. And if you look at, across kind of all medical specialties, consideration of pregnancy is often as a complication or risk of the condition, as opposed to recognizing it as part of the normal life course. And therefore it's excluded in research. It's not considered. We're talking about the past, but first guidelines for management of cardiac disease in pregnancy were only published in 2011. And in the National Programme for Cystic Fibrosis in Ireland, published in 2017, there was only one line in relation to pregnancy or parenthood. So I think that thankfully is changing, but I think it's a huge frame shift that has to happen, and that's through policy, through advocacy. There's so many different ways, and even the fact that we're sitting here today having this conversation, I think, shows how much times have changed, hopefully, but that there's still so much more to do.
Great. Thank you. Thank you for that question. We've two more as well. We'll just take them all at once. And then there's one over here. And then can you put your hand? Oh, yeah. Okay. Thank you. Great, thank you. And we have a question over here as well. Just if you, yeah, well done. Great, thank you. Three very different questions. We might start with the one about cultural awareness. Fergal, maybe you could take that one. Thank you. Thank you for your question.
It's an excellent question, and thank you for asking it. I have to say that the Rotunda has always championed inclusivity and doing whatever it can to reach out to all of its communities. So that means that in our research programs, first of all, when you're bringing it through your ethics committee, you have to justify why if you're not being inclusive, you have to explain that. So that drives you to ensure that you're inclusive. You have to show that your recruitment materials are appropriately presented in a range of languages and in a range of different formats that will get to the total population of patients that attend at the Rotunda. So we know from caring for patients from marginalized, disadvantaged communities that approaching them, you can't approach all communities in the same way. The reading material that you provide, social media material needs to be pitched differently for different communities and needs to be culturally sensitive. And we do that quite well, I think. And our ethics committee actually requires that and expects that of you. I think on sterilization, abortion care, we have greatly improved since the amendment in 2018. There is now vastly improved access to abortion care, and thankfully now in all 19 maternity units, Cliona will be able to speak with authority on this. But I do think that, and the easier access now to free contraception for younger people now has vastly changed, the lie of the land in that regard, as evidenced by the fact that our teenage pregnancy rates have plummeted compared to what they used to be. The number of people under 19 pregnant is a fraction of what it used to be. And one of the other things that our research team with Zara and Elisa and Holly have been doing is are debunking the myths, getting messaging out there based on our research infrastructure, getting messaging out there on public health education, on our bodies, sexuality, STIs, contraception, general education. And that's all part of our responsibility.
Great.
It's probably too complex to get into molecular
I was going to maybe Jen, would you have a thought on that, designing drugs and kind of qualifying what is a safe one to go forward with?
Yeah,
or not?
I mean, I think in fact we were talking about research about to be started, and hopefully with our new study partum, which is going to be looking in the postpartum period at aspirin and heparin, that we will hopefully do a study with in the trial where we'll collect blood sampling and look at EVs and different proteins in the postpartum serum, so that therefore we can look and see whether or not aspirin impacts on that. And so that's something that we're hoping to do. And certainly the RCSI group and Fionnuala, through her partnership with RCSI and UCD, has done a lot of work in the neonatal sphere on preterm delivery, and looking at, I know that's in the newborn and neonatal period, but and looking at drugs and also serum markers and changes. We've spoken about hormonal changes as well. And just even with drug use in pregnancy, there's such a huge cardiovascular change throughout, from the moment someone has a positive pregnancy test to kind of 6 weeks postpartum. There is increase in blood volume, there is change in renal blood flow. So many things that will impact on drug utilization by the body. So all of those things, if we're pregnant, people are being excluded by trials, can't be taken into consideration and need to be.
Absolutely. Cliona, did you want to say anything on that?
So with regard to ethnic inequality, I think it's really important to have in mind, and we in the National Women and Infants Health Programme have that on the agenda all the time. The National Maternity Care Experience Survey has come out, and what we did notice from that is the responses tend to be lower in those from kind of migrant or underserved communities. So when we go out and look for responses, it tends to be those, with higher literacy levels and people, more used to, I suppose, the Irish system. So we're still looking for ways to capture, I think, responses from people who, have come from different cultural backgrounds and maybe are more recently in Ireland. There is an ethnic inequality project which will be published soon, that they've been doing some research down in Cork. And I think the responses out of that will be really interesting about people's experience of the healthcare system. So I'm interested to see that. But I think all the time, regardless of what we are looking at, for example, postnatal hubs where women have an opportunity to come with their babies after the baby is born and, discuss various things. We have been very clear to try and make that accessible for people. And actually, one of the things that we found is that for those who don't have an extended family around, that actually it was a source of support with regard to either breastfeeding or bottle feeding. So I think having it on the agenda the whole time is really important, but more needs to be done for sure.
Great, thank you. And just in the interest of time, I'm going to wrap up now. I'm afraid that's a trapdoor that's going to open and swallow us all up because time is up. But I did want to ask each of our panelists to finish by, I'd like to ask just a rapid fire round. What would you like to see happen now or in the near future, so it brings about more equitable and timely and effective support for women's health? Harriet, any thoughts on that? Can we learn from the past?
Yeah, I think I run frequently in the college events looking at the history of medicine, and one of the things that the clinicians who come to them say is that they was doing sometimes the same mistakes and sometimes the same thing coming up. So I definitely think there are things that can be learned from the past, but also that medicine has changed so much and so rapidly. I know we were talking about the access. I think Cliona, you were the first female chair of the institute. Is on their 50th anniversary. So the institute's based in my college for obstetricians and gynecologists, and it was the same for their 50th anniversary. It was the first female chair and the first female master of the 3 hospitals. So even like the access coming through is changing. People's expectations are changing, rightly so. They're expecting more, but it does put the pressure onto the profession.
Thank you. And Cliona, what would you like to see happen to enable that more equitable access? And
I suppose it has been helpful in the last while to talk about women's health, to move it up the agenda, but it would be great to be at a stage where you didn't have to.
We're just talking about health.
Talk about health, and that an expectation that regardless of where you are in your life cycle or regardless of gender, that actually you have good access. And I think the thing to remember is that, bias can work both ways. And so that we have to guard against that as well. But you know, it's equity. I think through the prism of equity is what you need to look at. And, you know, some of the inequity we have now is, you know, to do with, you know, people's different experiences or where they've come from. And so we need to work on that at the moment as well. But yeah, it would be great not to have to specifically have an event about women's healthcare and research, you know.
Yeah, maybe next year.
Yeah.
Next year. Thank you, Jen.
And I think certainly we've seen, you know, femtech is really taking off. And up until, I don't know, I'm sure someone here can say when, you know, on our iPhones, it started to have period trackers. Like that didn't, it was years after iPhones existed that happened. So we need to have awareness raising and advocacy. And then because it's only that will push investment into our services to kind of to develop them, and that they can't be left behind, and that there has to be all of the groundwork, the advocacy, the public investment, the policy that will drive, you know, further investment, so that, as Cliona says, that it's not just, you know, it's not just an afterthought, it's part of the development from the beginning, that everyone isn't your average 70 kilogram man, you know, that, you know, and you have to be designing drugs not just for one particular standard, but taking things throughout in loads of different ways and throughout different ages.
Great, thank you. And Fergal?
Well, I think it's an easy one. It's resources, resources, resources. I think there is no doubt for many years, in response to your point, for many years, women's health services, both in terms of health care and indeed research, have been relatively underfunded. We still have very busy maternity hospitals here are significantly underfunded for what they do. We have fabulous researchers. We have really dynamic people who are doing great work, would do even more if they were resourced. And there is absolutely the potential for Irish health services, in particular women's health services, to be an international exemplar of how to do things right if we were adequately resourced to some great people doing great work. And let's just see if we can make it happen.
Great, that's a brilliant call to action to end on. Thank you so much, Fergal. Thank you to everybody for coming along today. Thank you, Research Ireland, for supporting Science Week. Thank you, everybody involved in BIAS. Eliza, Zara and Holly, you're always a joy to work with. And everybody who was involved in bringing things together today. Thank you, Robin. I haven't looked behind me, but I'm sure it's a masterpiece. It's full. It's very, we did a lot of talking. And thank you so much to Orla and Quiva, our ISL interpreters who've been working so hard. Thank you to our panelists, to Fergal, to Jen, to Cliona and to Harriet. And thank you. Thank you all.